Ever seen a newborn with a soft little bump on their head
Oh.
that can make you pause, maybe worry a bit?
Yeah, it's definitely something new parents notice.
And it's actually pretty common. So today, we're going to do a deep dive into one specific type of that swelling, cephalohematoma.
That's right.
We're working from some detailed revision notes, and the plan, our mission, is really to get crystal clear on this for revision purposes.
Everything from what it is, why it happens, right through to potential complications.
Exactly. Okay, let's get into it. So, what exactly is a cephalohematoma?
Well, it's interesting because it sounds a bit alarming, but fundamentally, it's a collection of blood.
Okay. Blood where, specifically?
It gathers in the space between one of the baby's skull bones and the periosteum. That's the membrane covering the outside of the bone.
Right, the periosteum.
Yeah. And you just see it as a kind of localized swelling.
Yeah,
The notes mention it's often on the parietal region.
which is sort of the upper sides of the head towards the back.
Exactly that. And it's not always just the bump itself we need to think about.
Ah, so there can be associated conditions? What sort of things?
Well, if it's a fairly significant collection of blood, it can sometimes lead to anemia,
Low red blood cells?
precisely. And, though less common, potentially hypotension, low blood pressure,
Eh,
and also hyperbilirubinemia.
jaundice.
Yeah, from the body breaking down all those collected red blood cells.
Oh, okay.
And here's a really key point from the notes sometimes. There might actually be an underlying skull fracture.
Oh, right, so that's more serious.
It can be. And because of that possibility, if there's any real suspicion, imaging like a CT or maybe an MRI scan might be needed.
Okay, makes sense. So what about how long these things stick around? Do they just go away?
Typically, yes.
Hmm.
They usually resolve on their own over several weeks.
Weeks, okay.
The notes do mention that sometimes, even after it's gone, there might be a little bit of residual calcification. You might feel a slightly firm spot.
Hmm.
And it's worth saying, although it's rare, infection is a possibility. Not common, but possible.
Got it. Okay, so that's the what. Let's
Yeah.
talk about the why, the etiology. What actually causes it?
The main cause, laid out clearly in the notes, is trauma, specifically trauma to the head during delivery.
Right. The whole birth process.
Exactly. It's quite a journey for the baby's head. And several things can contribute. Prolonged or difficult labor is one factor.
That makes sense. More time, more pressure.
Yeah. And the use of instruments like forceps or maybe a vacuum extractor,
Ah, instrumental delivery.
that can play a role too. But even just the normal pressures during a standard vaginal delivery can sometimes be enough to rupture those tiny blood vessels.
So it doesn't always mean something went wrong,
But
necessarily.
necessarily, no. It's
Yeah.
often just part of the mechanics of birth.
Okay. So are there specific things that make it more likely? What are the risk factors mentioned in the notes?
Yes, there are several listed. Being a first-time mom, Primiparity seems to increase the risk slightly.
Okay.
Instrumental delivery, like we just said, that's a big one.
Yep.
Also, babies with a larger birth weight. And again, prolonged labor comes up.
And anything else?
Interestingly, the notes also mention male gender as a potential risk factor.
Huh. Okay. And how common is it overall?
The estimate given is around 1 to 2% of newborns. So not incredibly common, but definitely seen.
1 or 2 in every 100 babies, roughly. Okay. Let's dig a bit deeper into the pathophysiology. What's actually happening biologically?
So that trauma we talked about during delivery causes some small blood vessels to break, specifically the ones between the skull bone and that periosteum layer.
Right.
And this creates a kind of potential space, and blood slowly fills it up.
Slowly. So it might not be obvious right at birth.
Exactly. It might become more noticeable over the first day or two as the bleeding continues a bit.
Okay.
And here's a really, really crucial point for distinguishing it. A cephalohaematoma is almost always confined to one skull bone.
Meaning it doesn't cross the lines between the bones?
Precisely. It does not cross the suture lines. Those fibrous joints between the skull plates act like boundaries.
Okay, that seems like a key diagnostic clue.
It absolutely is. It's fundamental.
So if you see swelling that does spread across those lines, you'd think of something else.
Immediately. Yes. And that leads us perfectly into the differential diagnosis. What else could it be?
What are the main contenders?
The notes highlight a few key ones to consider. There's subgaleal hemorrhage,
Okay.
caput succedaneum,
Right, kaput. Hear that one a lot.
and also subdural hematoma, which is obviously more serious.
They sound like they could look similar initially. How do you tell them apart?
Well, careful clinical assessment is usually the first step.
Mm,
For instance, caput succedaneum, that's more swelling of the scalp's soft tissues. It feels boggy, and crucially, it can cross suture lines.
there's that key difference again.
Exactly. Subgale hemorrhage is bleeding into a different space
Mm,
under the gilia ponderotica, and that can spread much more widely and be quite dangerous.
right.
And subdural is bleeding inside the skull itself, under the dura. So while the physical exam often gives strong clues, sometimes imaging is needed to be sure, especially if you're worried about something more serious, like a subgaleal or a subdural.
Got it. Clinical signs first, imaging if needed. Okay, let's just circle back quickly to epidemiology. We mentioned 1–2%.
Yeah, the notes say that while precise UK prevalence isn't perfectly established, that 1–2% figure is the generally accepted estimate.
Okay, consistent figure then. So thinking about clinical features again, a parent or a clinician sees this bump. What else might they notice or not notice?
Well, importantly, the notes stress that these are typically painless for the baby.
Oh, that's good to know.
Yeah, very reassuring. And usually no neurological symptoms either. The main sign is that soft, sort of fluctuant, meaning fluid-filled swelling on the scalp.
And usually just on one side.
Usually one side, yes. Often parietal, like we said, or sometimes occipital at the back.
Oh, yeah.
Confined by those suture lines, doesn't cross over. And remember, it might actually get a bit more pronounced in the first few days after birth.
Before it starts getting better. Okay.
Yeah.
So if the clinical picture points strongly toward cephalohaematoma, what investigations are typically done?
Primarily, the diagnosis is clinical, based on the examination, feeling it, seeing its location, checking that it respects the suture lines.
So not routine scans for everyone.
Yeah. The notes mention imaging, like ultrasound or maybe an X-ray comes into play if there's a specific concern, like suspecting a skull fracture or if the presentation's a bit unusual and you want to rule out other intracranial issues.
Okay, so clinical diagnosis is the norm. What about management then? What's the typical plan?
The really good news here is that most cephalohematomas just resolve spontaneously. They go away on their own.
How long does that usually take?
Generally weeks, maybe up to a few months in some cases.
Okay.
So the management is usually what we call conservative, basically watching and waiting.
Just monitor.
Yeah, monitoring the swelling, making sure it's resolving, and keeping an eye out for any signs of those potential, though rare, complications.
Like infection.
Exactly. So the focus is really on comfort for the baby and preventing infection. Usually no active treatment like drainage is needed.
That sounds very reassuring. What about the long-term outlook, the prognosis?
Generally excellent. The notes are clear on this. Most resolve completely without any lasting problem.
That's great.
The only things that might affect prognosis are those rare complications like an infection getting into the bone or if there was an underlying fracture that needed attention. But again, these are uncommon.
So it looks worrying, but usually isn't a long-term issue. Let's focus on those complications, though, just so we know what to look for. What are they?
Sure. So number one is infection. The notes mention osteomyelitis, bone infection, or an abscess forming.
Okay. How would you spot that?
You'd look for signs like increased redness, warmth over the area, maybe more swelling, or the baby developing a fever, or being generally unwell.
Got it. What else?
Anemia, if the blood loss into the hematoma was significant.
Right, we mentioned that earlier.
And jaundice, or hyperbilirubinemia, from the breakdown of those red blood cells in the hematoma.
So monitoring bilirubin levels might be important, too.
Yes, particularly in the first few days. So monitoring for infection signs and keeping an eye on jaundice are key parts of the observation.
Okay, this has been really clear. Now, for revision, memory aids are always helpful. Any mnemonics or tips for cephalohematoma?
Definitely. For the definition itself, just break down the word. Cephalo means head. Hematoma means blood collection. Simple but effective.
Head blood collection, okay.
For those risk factors, Primiparity, instrumental, large weight, prolonged labor, male gender, maybe something like Pillman.
Pillman, P-I-L-M-N. Okay, I can work with that. Primiparity, instrumental, large, male. Prolonged labor, male. Got it.
Yeah, the N is just to finish the word, but it helps group them.
Mm-hmm.
And the absolute key differentiator. Caput crosses sutures, cephalo does not. Burn that one into your memory.
Caput crosses, cephalo confined. Perfect. Shall we try a quick practice question, like an MSRA style one?
Yeah, let's do it. Okay, a full-term baby is born using vacuum extraction after a long first stage. On day 2, you notice a firm, non-tender swelling over the baby's right parietal bone. It feels contained and doesn't cross the midline. What's the most likely diagnosis? A, caput succedaneum, B. subgaleal hemorrhage, C. cephalohaematoma, D. subdural hematoma.
Okay, so vacuum prolonged labor are risk factors. It's localized, firm, it doesn't cross the midline. Sounds exactly like what we've discussed. C, cephalohematoma.
Spot on. Okay, another one. Which of these is least likely to be part of the initial management for a straightforward, uncomplicated cephalohematoma? A. Monitoring for infection signs. B. Immediate surgical drainage. C. Ensuring good feeding. D. Observation for it to resolve on its own.
Well, we said management is usually conservative, watching and waiting, focus on comfort and preventing infection. So immediate surgical drainage, B, sounds least likely.
Correct again. Surgical drainage is rarely needed. Okay, one more. A cephalohematoma breaking down can lead to which complication? A. Hypoglycemia. B. Hypocalcemia. C. Hyperbilirubinemia. D. Hypernatremia.
Ah, the breakdown of red blood cells releases bilirubin. So C, hyperbilirubinemia causing jaundice.
Excellent. So you've got the key points locked in.
These really help solidify it. Any final memory tip for the overall picture?
Just remember the prognosis point. Complications are rare. Most resolve fine on their own. Don't let the initial appearance cause too much alarm, but do monitor carefully.
Perfect. This has been incredibly helpful, really breaking down cephalohematoma. I think the key takeaway for everyone listening is, yes, a head bump on a newborn needs attention, but a cephalohematoma is usually benign, self-resolving, but does need that careful monitoring for those uncommon complications.
Absolutely. And it makes you think, doesn't it? A sort of provocative thought, perhaps. How might different delivery practices or maybe closer monitoring during labor actually impact how often we see cephalohematomas? Something to mull over.
Definitely food for thought. And listen, if you want more resources for your MSRA revision or just to learn more, do check out passthemsra.com.
And also freezemsra.com for, well, free resources. Both are really useful.
Great suggestions. Okay, that's it for this deep dive. Keep up the fantastic work with your revision, and we'll catch you on the next one.